Respected judges and good morning everyone. So we'll discuss about the comparative analysis of Loteprednol 1% and Prednisolone Acetate 1% following NdYAG peripheral iridotomy, a prospective observation study. A laser peripheral iridotomy is the procedure of choice for angle closure glaucoma caused by relative or absolute pupillary block. LPA eliminates pupillary block by allowing the accused to pass directly from the posterior chamber to anterior chamber by creating a small opening in the iris bypassing the pupil. LPA can be performed with an argon laser, with an NdYAG laser, or with both. While the procedure is highly effective in lowering intraocular pressure and preventing further optic nerve damage, the transient post-procedure inflammation is a common concern. Topical corticosteroids are used after NdYAG iridotomy to suppress inflammation and minimize this complication. However, their comparative safety profile remains an important clinical question. So the purpose of my study is to compare the safety and efficacy of 1% Loteprednol eye drop, a soft steroid with a favorable safety profile, with 1% prednisolone acetate, a strong steroid after NdYAG peripheral iridotomy. So we included all the patients who were diagnosed as primary angle closure and primary angle closure glaucoma based on International Society of Geographical and Epidemiological Ophthalmology classification and were above the age of 40 years, and excluded history those who were having history of uveitis or active inflammation, non-steroid responders, prior ocular surgery in the study eye, and allergy to study medication. Informed consent was obtained from all the patients. The study was conducted at Comtrust Eye Hospital, Kozhikode, from November 2024 to May 2025, and patients were 274 eyes were analyzed, and patients were given lots and were divided into two groups. Each group contains 137 eyes. And the group 1 received Loteprednol etoposide 1% for BD, and group 2 received prednisolone acetate for QID. And initial setting of 2 millijoule then increased to 4 millijoule until iris was fully perforated, followed by gush of accus was seen. And follow-up was done after 1 week and 1 month. And the primary outcome measures were anterior chamber inflammation, which was graded based on Sun classification. IOP was measured using Goldman applanation tonometry. And secondary outcomes include rebound iritis, ocular discomfort, patient-reported symptoms. And the statistical method included chi-square test, and a p-value of less than 0.05 considered statistically significant at 95% confidence interval. And the demographic characteristics of the study population, in which age, gender, initial IOP were comparable between two groups. Anterior chamber inflammation at 1 week showed slightly higher inflammation in Loteprednol group, but it was not significant. The mean baseline IOP was comparable, and after 1 week, prednisolone group showed slight elevated IOP, and after 1 month, values become almost identical between the groups. Rebound iritis occurred in 4.4% of Loteprednol group, and in prednisolone group it was 10.9%, and p-value was 0.03. It was found to be statistically significant. Coming to the discussion, according to Stephen Eslane in his study, he found that inflammation control was equal and effective between both Loteprednol and prednisolone group. And in our study, both Loteprednol and prednisolone were effective in controlling post-PI inflammation. These are the studies in which Loteprednol has a lower tendency to elevate IOP compared to traditional corticosteroids like prednisolone and dexamethasone. And in our study, over 1 month, both Loteprednol and prednisolone caused only a minimal increase in IOP. However, prednisolone showed a slight higher IOP at 1 week and 1 month, supporting the view that Loteprednol has a safer IOP profile. And by Kirti Gayam et al. In 2020, in their study, they found that rebound iritis occurred in the prednisolone group after NdYAG PI. This supports the fact that rebound iritis as a complication after YAG PA and is more likely with stronger steroids, consistent with our finding that Loteprednol had lower rebound rates. So to conclude, in prospective settings such as post-NdYAG PA management, Loteprednol 1% provides similar anti-inflammatory benefits to prednisolone acetate 1% and less likely to cause clinically significant increase in IOP. And the limitations of the study are a questionnaire on post-procedure pain, patient discomfort would have been added. ASOCT measurements of iris thickness may have included, and it has relatively short follow-up. These are my references. Thank you. Yes, sir, but
That has not been presented. Methodology, there's a mention
Yes,
which you
sir.
asked. Yeah, that's very important because when you do these lasers, then you will invariably ask about patient related. And what is the protocol for using prednisolone? How many days? What was the
both the steroids were used for 1 week, sir.
1 week? And then it was stopped, and then you check the rebound inflammation at 1 month also.
Yes, sir.
1 week and
1
1
week
month.
and follow-up was done after 1 month.
So first, prednisolone showed a higher rebound iritis. Can you tell me the protocol for the nepafenac use in the Kirti study? Do you remember that? It's a very complicated protocol for NSAID. It's not a very straight. How many times would you use NSAID? If you were to do the study with nepafenac, how many times would you use NSAID?
QID.
Yeah, usually it's TID, and but they had 4 times, and then they shifted to 2 times, and then it went on for almost 2 to 3 weeks. So it was a very complicated protocol for NSAID, whereas the prednisolone was straightforward. How would you prevent rebound iritis if you were to? Why does rebound iritis actually occur?
Sir, the prednisolone, since it has a ketone group, it's a strong steroid. It reduces the inflammation, and it also suppresses the body's immunological factor. Whereas Loteprednol, it suppresses the inflammation in a weaker way. So after withdrawing the prednisolone, it will rebound. Thank you.